Our next category is innovation and transformation of care. This category looks at those who have used innovation to improve quality, safety and effectiveness, have supported change through effective leadership and culture, have involved service users and carers, and have led innovation to facilitate evidence-based practice. And the finalists are Temporal Artery Biopsy, Northern Trust; Ambulatory Services, South Eastern Trust; Care Without Pyjamas, Northern Trust; COVID-19 ICU Follow-Up Clinic, Belfast Trust; a reformed OPAT service in the Southern Trust. And in this category we have joint winners. We have the COVID-19 ICU Follow-Up Clinic in the Belfast Trust and the Ambulatory Services in the South Eastern Trust. Congratulations to both teams. And first off, we're going to hear from the Belfast Trust about their project.
Good afternoon. I'm Dr. Rosalind O'Reilly, ICU consultant in the Belfast Trust. Thank you for inviting me to present today on behalf of the ICU follow-up team, and thank you for selecting our project to receive this award. Today I will discuss the background of our project, our QI methods and measures, and our learning for the future. It is widely accepted that critical illness can be a traumatic experience and can result in significant physical deconditioning. Patients often find the step down from hospital to home extremely difficult, and the impact of their intensive care stay can be profound. Previously, there was no formal follow-up service for ICU patients in the Belfast Trust, and we realised that patients needed comprehensive care to extend beyond their intensive care stay to maximise and support their recovery. This is why the symbol of our clinic is the dandelion, which represents healing from emotional pain and physical injury alike. Our vision was to improve the physical and psychological recovery for patients by establishing a multidisciplinary follow-up service. Our aim was to offer 6 and 12-week appointments post-discharge as per national guidelines to 80% of COVID ICU patients by September 2020. This was our vision because there have been multiple guidelines setting out the need for follow-up following critical care, with NICE stating that poor quality rehabilitation and impaired recovery from severe illness should be regarded as a major public health issue. Other faculties have subsequently set follow-up as a standard of care. Additional guidelines from the British Thoracic Society and Faculty of Intensive Care Medicine were produced specifically in response to the COVID-19 pandemic, both of which provided the basis for our clinic. For some context, this is a process map of what the patient journey from ICU looked like previously, with patients admitted to the Belfast Trust COVID ICU from multiple areas, and survivors discharged home from the medical ward. The purpose of the COVID ICU follow-up clinic is to bridge the often significant gap between ICU and home. It aims to support patients and their family at home to decrease avoidable and costly presentations to the GP. Follow-up clinic provides early and focused interventions, coordinates required outpatient services, and links with primary care to avoid unscheduled emergency attendance. The multidisciplinary team constructed a driver diagram to set out the change ideas required to achieve our primary aim. This gave us a plan and structure to focus us and meant we could implement changes in a manageable way. We created a wide MDT and we used a collaborative leadership approach to co-design this novel clinic using the national guidelines. The model for improvement approach was used and changes were tested with PDSA cycles. As there were many restrictions in place, we had to use new and innovative solutions to meet our targets and create an accessible and efficient service. Some of our tested innovations included a virtual MDT appointment system, which you can see in this photograph, a one-stop shop appointment with multiple specialty review, which we tested and secured appropriate facilities for, a live flexible rota system to ensure appropriate staffing and management of clinic bookings, a virtual platform for notes and collaborative note-keeping using live performers, able to be accessed by the whole team. We used a proactive approach with patient assessment questionnaires sent and electronically collated prior to appointments, such as this questionnaire. We also arranged standard investigations such as x-rays and bloods prior to the patient's appointment to avoid any delays in management. We immediately entered our electronic notes into ECR and posted a summary letter to avoid communication delays and enhance links with community care. These graphs demonstrate our outcome measures, showing that we achieved our aim of providing 80% or more patients with follow-up. They show the percentage of patients from COVID ICU who attended 6 and 12-week follow-up. We can't comment on any shifts or trends as this represents cumulative data, so we cannot apply run chart rules. The first chart demonstrates an increase in patients attending, and we achieved the aim of more than 80% of patients. Similarly, the run chart for the 12-week clinic, we've achieved greater than 80% attendance. And in particular, the last 4 data points indicate 100% attendance rate. This is not annotated with tests of change as there were so many changes implemented very quickly due to the nature of COVID-19 and working in a pandemic. And because we had to set up this entire service in a matter of weeks, it meant many changes were tested and implemented before the first clinic. The process measure for the project was the actual time from discharge to 12-week appointment, that is, 84 days. This demonstrated occasions where patients had a longer wait. You can see 4 were above the upper confidence limits. We investigated these to gather further learning. The first outlier was due to the rapid nature of how the clinic was set up, and this was the first possible time to see them. 1 patient was unable to attend as it temporarily left the country, and 2 were struggling with mental health issues. But by offering repeat appointments, they subsequently attended. There is 1 data point below the lower confidence limits, as the appointment was offered earlier as it was the final clinic of the first wave. From the third red circle, there is a shift in the data points below the centre line, and they stay there. This is highlighted in the oval shape. This demonstrates our improvement, with clinic appointment initially delivered at 100 days and decreased to around 84. As you can see, we also demonstrate the rule of 2 of 3, which also indicates that there is improvement. This improvement is due to us becoming more familiar with our system. Our process measure demonstrates that we improved on the delivery of the 12-week appointment to the correct time frame. As we now have a robust system in delivery of clinics, appropriately timed delivery of clinics may become our outcome measure as we move forward. In understanding our new system, we collated data on onward referral. This data is displayed in this Pareto chart. This reinforced the link required with these services and the importance of access to these specialties early in the patient journey. It has also enabled us to streamline our onward referral process into, for example, ENT, which unsurprisingly, with the nature of critical care, has a high referral rate. Our balance measure was patient feedback. This is a word cloud from free text areas in our feedback forms. We collected feedback at each stage of the process, and it was overwhelmingly positive. For example, 100% of patients stated the 6-week appointment helped them cope with their ICU stay. Furthermore, we specifically asked about all the specialties that assessed them, finding marked benefit in all of them. Our feedback demonstrated that patients were seen on time 100% of the time, and at a time that suited them. We explored the use of virtual clinics, and we found that patients did find this a very useful and convenient service. We also explored the one-stop clinic, where again the patients overwhelmingly found this more convenient versus multiple separate appointments. Here is a short clip from one of our patients when he shared his experience of ICU follow-up for a Trust social media video.
So when you got to the clinic, they had all the information that they needed. You've seen a whole range of specialists covering physio, pharmacy, speech, language, dietitian. Everything was covered in that one session, and all of our answers were basically all the questions that we had that we were looking answers for were covered. What happens next? Is there anything that I should be aware of? What, if any, other conditions am I likely to experience? And that's where the ICU follow-up clinic was a big help.
This patient also highlighted the huge benefit that his family got from attending the clinic. However, we had to edit this from the final video in case it caused confusion about families visiting the hospital during the pandemic. The process measure of time to 12-week clinic has demonstrated improved efficiency and utilisation of resource, and we have learned a lot for future clinics. Our team found that the model for improvement allowed for rapid learning and developing a follow-up service for COVID ICU patients. This has vastly improved my own learning and the team as a whole. QI and patient collaboration will become our focus as we continue to develop. Patient feedback was overwhelmingly positive. This work for COVID-19 patients has informed a business case for general ICU follow-up, and it is envisaged that the follow-up clinic will be an established standard for all ICU patients who may need it. The MDT was hugely engaged in this project as they knew the value and importance for patients from the start. Also, it was a massively satisfying experience for staff as they got to meet the patients again and take comfort in and contribute to their ongoing recovery. The Teams platform was crucial for collaborative, timely and robust assessments. We could ensure all investigations and tasks were completed, and it was easy to access for staff and patients. Early intervention has allowed prevention of long-term issues, normalisation of experience, and has picked up unresolved issues, which has streamlined patients' care. We liaised with the patient peer support charity ICU Steps for their input at an early stage of our clinic design and continue to work on this important partnership. And we are also engaging in the Rehab is Critical campaign. We have commenced a virtual rehabilitation exercise programme and have a patient advocate consulting on this. We are now working on other initiatives to bridge the gap to home, such as patient diaries, reimagining the Trust Critical Care website to provide resources for patients, and we hope to embed a point of contact for immediate post-discharge. Another recent initiative has been a podcast by the Ulster Orchestra specifically for our patients.
A warm and heartfelt greeting from the Ulster Orchestra. We are delighted to bring you this very special podcast with music chosen by our players especially for you.
We are continuing to develop and improve our service, and at the heart of that is the patient experience and journey. Thank you very much for listening.
Rosalind, it gives me great pleasure to be able to present you with the Innovation and Transformation Award. Very well done to you and your team.
Thank you very much, and really it's all the efforts of the team that has brought this about, all their enthusiasm from the start to make this project so worthwhile for our patients. So thank you very much for recognising that.
That was a pleasure.